I'm Caitlin Crossley from Optimity Advisors, and I'll be your moderator. Jackie Melender will be presenting. This webinar is about how to assess readiness for new models of care, a robust checklist for identifying local priorities and action plans. Before Jackie starts, I'd like to introduce today's speaker, explain how to ask a question using GoToWebinar, and finally, how to access the recording. Jackie Melender is a partner with Optimity Advisors and leads the public policy practice. She is a respected international economist specializing in the fields of health, justice, and education. Jackie has worked in many areas of healthcare throughout her 30-year career. Her experience includes the economics of public health, service and care pathway design, healthcare systems, and access to healthcare for vulnerable groups. Jackie's full bio is available on our website, or you can find her on LinkedIn. Today's webinar, How to Assess Readiness for New Models of Care, a robust checklist for identifying local priorities and action plans, is the third of a series of 6 webinars we will be hosting on evaluation methods. If you'd like to listen to our past webinars, please visit our website. And if you'd like to attend upcoming webinars, please let us know or send us an email. Before we get started, I wanted to mention that we welcome your questions throughout the webinar. All you need to do is type yours into the questions window, which, for some, is the 6th blue bar down on the GoToWebinar control panel, and hit submit. We'll get to as many questions as we can during the Q&A session after the main presentation. Finally, we're recording today's webinar and we'll post it on the Optimity Advisors website. We'll send you an email once it's up in case you want to watch it again or forward it along to a colleague. Without further ado, I'd like to turn the program over to Jackie.
Thank you, Caitlin. Before we begin, I'd like to quickly recap the highlights from the first 2 webinars. In our first webinar, How to Generate Value from Healthcare System Evaluation, which was an introduction to useful techniques and tools, we discussed evaluation, what questions we're trying to answer, how evaluation can help, what, when, and how to evaluate, and what tools can be used. In webinar 2, we discussed logic models. This is what a logic model for an evaluation looks like, and the key components. Logic model is a generic label for the many ways of displaying how change unfolds. It can support the work of models of care development and implementation by charting the course of transformation as it evolves. Logic models provides an overall strategy of the program and the solution to the problem you're trying to solve expressed in a common language. It makes very explicit, often visually and systematically, a statement of the resources and conditions required to deliver activities that will bring about changes and the results you expect to see for the health and social care community and its population. It's also very useful in identifying a roadmap or the steps required to deliver the program, and it provides some coherence of what are actually very complex interconnected tasks. So this webinar takes that concept one step further forward, and looks at how to assess the readiness of a system and/or barriers and enablers for implementation of these logic models in the context of new models of care. So if you're joining us for the first time, I highly recommend you go back and listen to both of the other webinars, as they really do provide the foundation of the tool that we're going to discuss today. So understanding readiness is essential. It helps to identify areas of risk and manage successful transformation to new models of care. The readiness assessment tool that we've developed is a validated system which combines qualitative and quantitative methods, self-assessment, as well as external assessment. Essentially, it provides a risk profile which will give you an indication of where the system currently stands on a range of domains, which we know from empirical evidence contribute to successful delivery of population health management systems. It is used to help prioritise areas of highest risk that need to be the focus of greatest immediate implementation effort, and highlights the domains where enabling support is required from the wider health and social care system, or national bodies. Various assessment tools have been employed internationally and subjected to considerable practical testing to help answer, where are we now? References to some examples of these are provided at the end of this webinar. We undertook a synthesis of these international tools and then road tested them in the English health system over the last 12 months. The resulting tool reflects the full breadth of competence, capacity and capability required to implement new models of care within a local health and social care community. I'm going to go through each of the domains in turn in this webinar. Broadly speaking, they cover strategic, cultural and operational issues and encompass requirements across the 4 programme implementation pillars of people, process, information technology and finance. So as mentioned earlier, the readiness assessment is really about identifying risks, barriers and enablers. To complement the tool, we've developed a risk scale which can be used as part of the assessment and can provide some risk assurance along the implementation cycle. So if you think of the implementation cycle as being ambition stroke design, then implementation, then improvement, the risk scale effectively allows you to see where you are through that cycle. So it starts, as I said, with ambition and design, where the programme risks are still being identified and management processes are still being put in place. Once you move to the implementation stage, risks are often known, but are obviously not yet fully managed because you haven't finished implementing. And then finally, when you've actually got a model that's working and implemented, you're still trying to continuously improve. And you know where the risks are, and you are actively managing those and adapting the model accordingly. So we basically adopt a scoring system across each of those aspiration, assurance, and resilience domains. And a score of 3, for example, which constitutes medium risk, corresponds to a model that has clear ambition and realistic design, but it is in the initial stages of implementation. So in other words, this is really a maturity index, which also looks at how mature the system is in terms of the journey of implementing new models of care. Each of the system readiness domains incorporates several individual dimensions for assessment. The allocated score is essentially a risk assessment of the ability to close the gap between the current capability and that required for the perfect system. This scale will be more practically shown in the case study towards the end of the webinar. In our experience, organisations and networks of organisations working towards new models of care vary in their profile against each of these domains at any given point in time. So by using this assessment, it will help the local system to identify its current capability whilst providing a framework for production and implementation of programme implementation development plans. And as I've mentioned in previous webinars, these naturally fall under the 4 broad pillars of implementation, namely people, process, finance and technology. Our use of the tool has helped health and care system leaders translate the risk assessment into an implementation strategy. Probably more important though, the best changes are not structural but behavioural. The biggest changes, are not structural but behavioural. And new models of care require clinical and non-clinical staff and patients to behave in very, very different ways. And this tool can really help to identify those qualitative dimensions. So let's start then with domain 1, purpose and understanding. There's very strong evidence from previous evaluations that key to success is a clear and shared vision which everyone signs up to. All those involved in delivering new models of care require a shared understanding of purpose. This needs to address not just what is delivered, vision, goals, financial commitment, etc., but the manner in which it's delivered, values, trust, transparency. The questions we ask in this domain therefore focus on this shared process. Questions include, for example, has the strategic direction been agreed with senior leadership champions? Is it in place? Has the strategic direction as well as clear objectives been written and communicated to the local health and social care community, including frontline staff and service users? This is actually a good example of a question that you might be asking of a system to test whether it's moved from the ambition stage. A question that you might want to ask at the implementation stage is, has the operational plan been finalised? Is it being implemented against agreed objectives? Surprisingly, often the answer to this question is maybe, not completely, or in part. A third question which might be asked when you're looking at a system that's been implemented and you're now monitoring improvement would be, is there a process for timely review to ensure the vision is still understood and embedded within the system? So all the way through this, you're looking at that shared purpose and understanding across all the stakeholders who need to be engaged. Partnerships are a key feature of new models of care. Partners will need to collaborate at a practical level across the whole care pathway to ensure safety, quality, effectiveness and efficient use of resources. The NHS and social care agencies in the UK are generally very experienced at partnership working, but may not always have identified all of the right partners and or achieved the right type of collaboration at all levels of the organisations involved, particularly in relation to the relationships between payers and providers. Success at the 4 Brookings Dartmouth sites require a transformation in the provider-payer relationship from an adversarial approach to a relationship based on joint problem solving towards shared aims. This required clarification on what those shared aims were between the payer and the provider, and openness about individual relationships. So for this domain, questions include, for example, has the full range of partnerships needed to deliver on the strategy been explored? This might be an ambition question. Is there a common understanding of what each partner is expected to contribute? This might be a design question. Are partners working to deliver against the operational plan? This is an implementation question. And then, do the partners have a plan in place for timely review of the proposed plans and partnerships against external changes in the policy environment? This might be one of the improvement questions. Moving now to scope. Commissioners and providers need a shared understanding of the scope of the service. This is important for operational planning, but also for performance monitoring and contracting. Scope should avoid both ambiguity in referral and acceptance practices, and mitigate the potential for gaming the performance measures. The Accountable Care Working Group state that within successful population-based accountable care systems, the population must be clearly and prospectively identifiable to both providers and the population themselves. And population selection should be based on prioritised potential value and based on a holistic view of spend across providers on that population. So when we look at scope in the context of new models of care in the NHS, examples of questions could include, are you clear about the scope, either geographical, demographic or health programme, of the programme? Has the scope been agreed and finalised? Both of those questions are required for the ambition and design stage. When you're implementing, are the services required available to patients identified as falling within the scope? It sounds like an obvious question, but often when asked, draws attention to some missing ingredients. And then, do you have a plan in place to review the scope and widen or narrow it down based on delivery experience? That's a very good improvement question when thinking about scope. The fourth domain takes scope one step further and considers population and patient focus issues. It's vital that stakeholders adopt a culture that places service users at the centre of service delivery. This should be demonstrated at the population level and the level of the individual service user, their carers, and their families. Providers must have detailed knowledge of the population, supported by in-depth profiling and analytical capability. International models and national pilots have identified the need for active engagement of patients in the delivery of their care, including shared decision-making and communication, self-management, medication management, changes in lifestyle. All of these are really key criteria for effectiveness, and patients can also contribute to the design of practice and share their experience of medical visits. So examples of questions that are asked under this assessment domain include things like, for the ambition stage, have patients and service users been engaged to determine what they want and need out of the system? Surprisingly often, patients are not engaged until later on when they're sent a survey after they've been treated. It's actually vital that they're brought in at the beginning, at the design stage. Another question at the design stage might be, have you undertaken a population analysis exercise to actually identify the target population? How many are there? What do they look like? What are their characteristics? Moving on to the implementation stage, a readiness question might be, are patients and carers involved in the care planning and decision-making processes? And does this include regular review of how well the agreed plan is working for them? And then finally, when you're looking at improvement, are you gathering feedback on patient and carers' experience? How are you gathering that? Is it meaningful? Is it a simple survey, or is it diaries, or are there forums? How are you making sure that patients are truly activated in relation to helping to ensure that your services are focused on their needs? So the next domain is governance. And we often hit a fairly blank looks when we start asking about governance. It's actually much more important than you might think. Governance is seen as getting in the way of innovation in many instances, but in fact, with really good governance, the reverse is the case. It can foster and fuel and give a permissive environment for innovation. Integrated models of care demand a strong governance regime in which the commissioner, the payer, can demonstrate how their accountability for the triple aim is discharged, whilst at the same time enabling the providers to accept ownership of the risk, while retaining the freedom to implement the necessary improvements and invest in innovation. Examples of questions from the readiness assessment here include things like, have the representative organisations for the governance structure been decided? Has a system-wide governance plan been jointly developed with all stakeholders, including the payer, and are all the reporting, communication and escalation processes in place? Moving to implementation, is the governance structure established in accordance with its design, as well as the people involved? And for improvement, is there a timely plan for reviewing the structure, making sure it's still fit for purpose? Local clinical commissioning groups will need to contract differently for the new service models. And essentially, provider reimbursements should support the delivery of the new model of care, and incentives should be aligned with outcome improvement. To enable this, lead providers and alliances will need to cascade the contract through their own supply chain to ensure resources are targeted in the right place at the right time. This is one of the more complex domains. Whilst there is general consensus that we need to change finance and contracting to enable new models of care, there is much less clarity about what in practice can be done by local stakeholders. Technically, there's probably more freedom locally to change the way services are paid for than local stakeholders might perceive to be the case. However, at a time when the NHS is seeking to recover financial control and local government are implementing serious funding cuts, it's a brave set of finance directors and CEOs who move to change the system locally, especially where it will enable movement of money across the system in the short term. Clearly, a strategic and staged response is required so providers and commissioners can manage this change whilst adhering to their fiduciary duties to make the books balance in the short term. So assessing readiness here, the kinds of questions that might be asked include things like an ambition stage. Have you actually agreed the financial envelope for the programme? Do you know how much you're spending at the moment on this target population across all of the suppliers who are going to be included in this new model of care? Have you agreed on a basic contracting model? Are you going for a lead provider framework? Are you going for an alliance model? Has the programme gone live? This is when you're moving on to implementation. And then moving through to improvement. Have you actually identified shared savings and agreed on whether to reinvest or distribute them? These are all important questions which show how mature a system is in relation to finance and contracting. Domain 7 focuses on professional practice. Providers are responsible for the maintenance of professional standards throughout the supply chain and must be able to demonstrate that they're working together to accepted standards of good practice, meeting agreed outcomes. Agreed evidence-based care pathways and procedures can support the delivery of coordinated care, but should be accompanied by regular person-to-person communication via formal and informal meetings and conversations. In successful integrated care systems, clinicians are empowered to adjust interventions to improve outcomes, and all team members are required to perform at the top of their license and use their skills to their maximum potential. So the kind of questions here include, do you have professional input and representation across the health and social care system in the design of the new care pathways? Do you understand how those care pathways are going to differ from those that have gone before? Has the operational plan been finalised and implemented against the objectives for change? And how is performance being monitored in terms of the agreed clinical outcomes, patient experience outcomes, and the relevant KPIs? I think this goes to the heart of it, because really under the new models of care and new models of integrated care, power to make proactive, safe but effective clinical decisions at the point that they need to be made must rest with those leaders in terms of professional practice, those who are actually at the front line delivering the care. And for that assurance that the professional standards are being met and that people are not care stinting or care shunting, this is what this domain is really all about, making sure that the professional practice is being monitored effectively. So one of the key features of new models of care is improved care coordination. Providers need to demonstrate how they're operating improved coordination of care in a local setting and how this links to expected improvements in outcomes and efficiency. So examples of questions here include, have you identified any gaps or junctions in services which provide opportunities for integration or for improved integration? Do you have agreed procedures for coordination of care across the supply chain? Both of those are ambition and design questions. An implementation question might be, do you have sufficient case managers to oversee the care of the highest risk groups? And then for improvement, how will you implement knowledge transfer, shared learning, and joint quality review processes? So by asking these questions as part of the readiness assessment, you can really see where is the local model of care in terms of progression through design, implementation, and improvement. How ready is it? When we've gone round using the readiness assessment process, one of the biggest challenges that we've faced with local health and social care systems relates to workforce. It's essential that workforce is engaged in the design and implementation of integrated care models from the beginning of the journey. I was speaking to somebody just this morning. She said, when I was being trained, I was taken to the top of the mountain. And then when I was given my job, I was told to come back down again and go into a box. And I think that we really suffer from the fact that people have skills and experience and expertise that we don't give them permission to use, and we don't give them permission to work together to use. So changing the focus of workforce and ensuring that we're investing appropriately in reflexive practice to ensure continuous learning, development and capability building in the workforce is really important. Examples of questions here can include, have you engaged with all levels of workforce to communicate high-level plans and gauge feedback? This is an ambition question. Have you built in a change management plan into the timeline? This is a design question. Are the services being delivered against an agreed care pathway by all the skills and the workforce involved? An implementation program. And then are we measuring workforce performance against objectives? And this is really to focus on improvement. I said at one of the earlier webinars that I've been trying to work with local health and social care systems to implement integrated care for probably my entire career. And why am I confident now that this might actually happen? Well, one of the big changes that's happened in my career is health information technology. It really is truly amazing how much this has changed, how much cheaper it's got, how much easier it is from a technological perspective to share information in a relevant way. All successful examples of implementation identify that information technology capability is fundamental to the ability to improve coordination, achieve better outcomes, and manage the gain sharing and contracting arrangements. At the very least, shared care records are essential if professionals are able to have access to the right information at the time when referral, treatment, and care decisions are being made. Without this, it really makes the system really complicated to implement. It's essential that these shared care records are an integral and seamless part of the workflow or care pathway, so that they're not an operational burden, they're an operational enabler. And beyond that, technology can also be an enabler for engaging patients, for monitoring wellness and treatment compliance and outcomes, and more analytically for population health risk planning and management. So there's a whole bunch of questions around the health information technology readiness domain. And examples here include, do you have a fully populated master patient index system that's available to all care providers in your supply chain and acts as a single identification reference for each patient? Have you set up a design team and governance structure? Have you educated, trained users on how to use the system once you've implemented it? Does your information infrastructure support effective clinical audit and longitudinal research across the continuum of care? That's a good improvement question. We're nearly there. We're on domain 11, and we've come on now to cultural readiness. Cultural readiness is covered by domain 11. The need for it shouldn't be underestimated. Stakeholders need to promote and develop those behaviours and attitudes that encourage systems thinking and good partnerships. This should also focus on the transformational changes required to be oriented on whole population health and to drive successful performance from the viewpoint of patient and community outcomes, rather than judged by clinical interventions alone. Early models of integration, such as the Premier Collaborative, identified significant culture change issues associated with becoming an accountable care organisation, including issues of power sharing, changing the organisational hierarchy, particularly where it involves allowing frontline workers to have more decision control, facilitating communication between physicians to encourage care coordination and shifting from a silo care delivery approach to a focus on the whole care continuum. So examples of questions about cultural readiness include, do you have a successful track record of managing organisational and clinical process change effectively? Do you know what you're doing? To what extent have staff already experienced the use of quality incentives to drive improvement? These are both ambition and design questions, so how ready is the culture to take this on? Is there a high level of engagement and trust between administrative, clinical and management staff and leaders in relation to strategic and operational decisions? This is a key implementation question. And then finally, our last domain we look at is resilience. We're very used to pilots in the NHS. For those of you who've dialed in internationally, I'm sure you feel the same way in your local health and social care systems. What we need to be sure of when we're implementing these new models of care is that we can demonstrate commitment to the solutions which have the resilience to be sustainable beyond the life of the pilot and/or indeed the contract. This is about putting arrangements in place that will withstand future changes, even if contracts are, for example, transferred to other organisations, as has happened. So examples of questions here would include things like, at the ambition stage, do you actually have adequate access to capital and resources to assume financial risk for the contracted population? Have you involved your partners in developing scenario models and undertaken sensitivity analysis to identify and eliminate key vulnerabilities? And then moving on to implementation, are your expected reimbursement systems transparently linked to risk and performance? And do you have a plan for timely review of the structure so that you can make sure, as I say, it is resilient to those external changes? So now finally, I just wanted to present an example scorecard. The scoring for this card was based on a series of interviews and document reviews, followed by a validation workshop with local partners covering corporate and professional leadership and frontline staff and patient representatives. It's actually a model, we called it the Accelerate New Models of Care. It was one of the pilot models under the Accelerate model, which looked at primary care, extensivist primary care model. Now the scoring shows areas of notable progress. So at the local level, for this particular pilot, there was a lot of strength in relation to developing and sharing between partners a clear and focused purpose and understanding of the service to be provided. There was a really clear, concerted population and patient focus with really good levels of ongoing engagement. There was a clear and focused scope of the service and a skilled and innovative workforce. But an area where this particular pilot had really struggled with implementing their logic model was around engagement with the payer, and particularly in this context on financing and contracting mechanisms. There was also here a barrier insofar as system-wide commitment and engagement to develop health information technology capabilities. One of the struggles, for example, is that you need critical mass and scale to implement the health IT technologies. So you have a small pilot that's supposed to be demonstrating whether a new model of care will work or not, but if it's not enabled by the infrastructure that's required to make it happen, it's really very hard to demonstrate anything other than a piecemeal elements of the logic model. So essentially, the investment required to make the changes for these two domains around finance and contracting and health IT went well beyond that justified solely by the pilot programme. So in taking forward the new model of care locally, it was clear from this evaluation that scale is required for this to succeed and for the full benefits of the model to be realised. Now, I promised to finish with some useful references which we used for the tool development itself and which are shown above. I'm now going to hand back to Caitlin to moderate the questions, and I'm going to leave this slide up for a moment so you can take a screenshot or note some of the titles. Caitlin.
Thank you very much for that, Jackie. We've received quite a few great questions so far, but there's still time to ask one if you haven't submitted yours yet. As a reminder, if you go to the GoToWebinar control panel, there'll be a panel that says questions, and within that questions box, you can submit. So the first question we have, Jackie, is how long does it take to do a readiness assessment?
Thanks, Caitlin. I think the answer is it depends. A readiness assessment can usually take 2 to 3 weeks. We have a preparation period where we would interview some of the local stakeholders beforehand. If you like, prepare some kind of stalking horse or Aunt Sally. And then we would go in and run a workshop with the stakeholders and feed back some of those initial findings based on interviews and document reviews. So it could take 3 to 4 weeks to get a really good readiness assessment done. I think the point is that you want to keep doing them, and to a certain extent you want them to be partly a self-assessment. So the whole idea is to get the stakeholders themselves to say where they think they are, and you know you've got it right when the stakeholders are telling you as evaluators that you're a bit too optimistic in terms of their scores. When people are saying they're not as far ahead as you as evaluators might think they are, then you really know you've achieved something useful.
Great, thank you so much, Jackie. That's really helpful. The next question we have is, there's a lot of assessment tools available, but what makes this approach different?
Well, it's evidence-based. The tool has been developed by successful evaluations that have been done elsewhere and the findings from those evaluations. So it's the evidence base for each of the questions and each of the domains is pretty robust. The other thing I think which is unique, I guess, to this tool is the way it's done in terms of involving the local stakeholders themselves in becoming more self-aware about what's needed to implement the system and how ready they really are in terms of implementation and the progress that they're making. So it's very much a co-design, and in actual fact, each time we run one of these assessments, we've modified the questions very slightly to take into account the needs of the local situation. I think what's really important is that the domains are very comprehensive, and they do really cover not a partial perspective of whether we've got outcome-based contracting set up correctly, or we've got a care pathway set up correctly, or we've trained new staff. The 12 domains really allows you to cover all of the dimensions that the evidence base suggests are needed for new models of care to be effective.
Okay, thanks very much, Jackie. And the final question that we have is, with the pressure of limited time and resources that we're all facing, how does one get leadership buy-in to undertake a readiness assessment?
Well, I think it goes back to the point of how much money you're investing in these new models of care. How much are they actually costing? How many resources are being put into the program management of these? How much time is being spent by those health and social care professionals who have to stop doing their day job and start thinking about planning to make these changes? So if you think about the level of investment that's going in, either budgeted or not budgeted, doing a readiness assessment is a really low-cost attempt to map the gaps and identify the barriers and enablers, and can be a really cost-effective, formative evaluation tool that really helps the program to understand its direction of travel. Great,
thanks very much, Jackie. Well, unfortunately, we've run out of time. If we didn't get to your question, please feel free to email us and we will follow up with you directly. As a reminder, the recording of this webinar will be available within the next 24 to 48 hours and available on our website. Our fourth webinar in this 6-part series is on the 24th of March at 11 a.m. with Gareth Harper. This webinar will focus on evaluation for economic of new models of care. We hope you'll be able to join us. Thanks again for joining us today, and we hope you'll be back at the next Optimity Advisors webinar. Thank you.